Preston, president of Power of Parkinsons, and today, in conjunction with our Pop Profile series, we have an extra special interview as we have Dr. Gordon Baltuch from the Columbia University Medical Center within the Division of Functional Neurosurgery here for our first in-person Pop Profile interview. So thank you so much, Dr. Baltuch.
Thank you so much for inviting me, Margaret.
Yeah.
This is just fabulous to be here in Richmond.
This is great. So Dr. Baltuch specializes in the surgical treatment of movement disorders for over 30 years. He's performed over 1,600 DBS procedures and is one of the pioneers for the new 2016 approved Focused Ultrasound procedure, and has completed hundreds of those procedures, and we're thrilled to have him with our series.
Thank you.
So if you're ready to jump into our questions, kind of pinning DBS versus Focused Ultrasound together, we'll get started.
Well, yeah, great.
All right. So at a high level, Dr. Baltuch, can you explain what DBS, Deep Brain Stimulation, is and what is entailed in the procedure?
Yeah, so basically, deep brain stimulation is placing wires in small structures deep in the brain and connecting those wires up to a pacemaker and then sending electrical signals into your brain and changing something in the brain in order to impact motor symptoms of Parkinson's disease. So you can look at it as either like a brain pacemaker as opposed to a heart pacemaker, or you could look at it as a form of electrical medicine versus taking pills.
Yeah. Yeah. So share with our listeners who would be eligible for the DBS procedures.
So deep brain stimulation has been used for a variety of conditions, Parkinson's disease being one, and probably the one that has been most commonly used for. So then the question is, who with Parkinson's disease is eligible or a candidate indicated to get deep brain stimulation? So in general, there are a lot of different ways of looking at this, but I think that if you have Parkinson's disease and you're being treated well with your medicine and you feel pretty good, then you're not a candidate for this procedure. This is a procedure for someone who either is starting to have problems with their medication, so they're having the ups and downs of the medications. Either they're going off at funny times, and it's sort of what we call poorly controlled motor fluctuation, so they fluctuate, or they feel they're taking too much medicine and they're having problems with the medicine. They just keep taking pill after pill after pill, or they can't tolerate the pills that they're taking. The pills either make them feel sick, or the pills are making them do funny things, potentially socially irresponsible things associated with some of the pills are a problem. Or potentially, let's say they have really bad tremor from Parkinson's disease and their tremor is just not really controlled with Parkinson's disease. So those are the people who we look at as surgeons who get sent to us for potentially for PD. So I look at it, usually it's people who've had Parkinson's, usually at least 5 years. From diagnosis. That's sort of where we look at it. Sometimes a little less, but mostly at least 5 years. And it's got to be, to come for a neurosurgical procedure, I think that Parkinson's disease has to really sort of almost like taking over your life. Like you're dealing with your Parkinson's all day long, instead of like, I can take a few pills and forget about it and go on with my life, and I don't think about having PD. It hasn't started to dominate my life. So I think in order to go for something like neurosurgery, I think that Parkinson's disease really has to be a dominant force sort of in your life and get in the way of your life in an important way.
Okay, so those truly impacted by the disease would be a good candidate where it's taking over the quality of life.
Right.
Is declining.
And you're under best medical care, and you're doing all the other things. You're doing your exercise. You're going out. You're doing all your ancillary stuff. You're really doing the best that you can as a person, and the PD is still really impacting you in a negative way.
Now, are those who are experiencing dyskinesia as a result of long-term levodopa usage eligible for this procedure?
Yeah, those are excellent candidates. Right. If you're developing bothersome dyskinesias from Parkinson's disease, the deep brain stimulation can get rid of those dyskinesias by two different mechanisms. One way is by thinking of DBS as a form of electrical medicine. You can place a deep brain stimulator in use the deep brain stimulation, the electricity, and then decrease the medications that are causing those dyskinesias. So you take, let's say, half as much medication and you don't get the dyskinesias anymore. Or another way is to place the stimulator in a target known as the globus pallidus internus, which directly impacts on the dyskinesias, in which you can continue to potentially take the same amount of medication as you did before. Potentially you need that, but the dyskinesias get blocked by the stimulation itself. So really two mechanisms. If you look at classically in terms of what DBS does in terms of literature, when we did these studies, and I know Richmond, Virginia was involved because the VA in Virginia was involved in the classic sort of VA NIH study, which was CSP 468, was what it showed was that deep brain stimulation gave you 4 to 6 extra hours of good on time a day without dyskinesias compared to a cohort that had best medical therapy.
Okay, that's a great takeaway and a good soundbite for folks to kind of understand numerically kind of how it shakes out. Now as we talk about hardware, we'll talk about risks associated with the procedure, but what maintenance is required with DBS if we're talking about hardware and implanting hardware?
Yeah, so deep brain stimulation requires hardware. There are various forms, there are various makers who are making this now. I used to be one sole maker, now there are 3 in the field, and there'll probably be more that develop. Classically, the pacemakers needed to be changed every few years. And classically, that was every couple of years we'd have to change. You'd come in, you'd get sedation, you'd get your pacemaker switched. Now in the last few years there's rechargeable technology. So people can recharge, and I think society is much more used to with phones and rechargeable. That has not been a big problem. People thought it would be at the beginning, but it has not been a problem. So a rechargeable pacer you can have for 15 to 25 years and never have to change it at all. Now programming the pacemakers is something else. So programming the pacemaker is like adjusting medicine. You go in and you get your pacemaker programmed. Some of the newer things that have happened with one of the makers now, which we were very pleased to see with COVID, is you can get your programming remotely now with one of the makers. So you could sit at home and put an iPhone or something over your pacer and have your neurologist do your programming remotely, like people have classically done with cardiac pacemakers. And then the newest thing, which is investigational and not approved, but we're getting there, is going to be what we call adaptive stim. And that's going to be, now the pacemaker can sense your Parkinson's disease motor symptoms through brain waves, like a radio wave in your brain. So there'd be, let's say, certain radio wave that's associated with certain motor symptoms of Parkinson's disease. We'll call that beta band, right? When the beta band goes up, your stimulator knows, okay, now it's time to send in electrical medicine to get the beta band to go away. When the beta band goes down, it sends less electrical medicine. So now you've got an automatic programmer inside, which is programming your system on itself. And you have intelligence, and this is basically a form of AI, right, inside a pacemaker. And we're hoping we'll see more and more of that in the next sort of 5 to 10 years, where you'd have internal programming and you wouldn't have to go to programming sessions, you'd have that maintained on your own. Now, of course, when you get this type of programming, your neurologist will also be changing your medications based on the things like you said before. Having abnormal movements, correcting your medication, so as this goes up, you can take less medications. Sure.
To kind of elaborate on that a little bit more, share with our listeners the potential risks associated with the procedure.
Well, deep brain stimulation is it's neurosurgery. I mean, it is neurosurgery, and neurosurgery carries real risk, and and there are, you can die from a neurosurgical procedure, you can die from the anesthesia. There's a 1% risk of having a major stroke, and there's a risk of infection, which I think is about 4 or 5%, which to people it just sounds like, wow, it's neurosurgery. You could die from this, and you could have a stroke from this. This is awful. However, going back to the study part of which the people in Richmond participated in, if you look at the cohort, when we did the study some years ago, we took people and we either said, okay, you're going to get deep brain stimulation, or your doctor's going to continue on the best medical regimen. You know, we'll take those two cohorts and we're going to see how everybody's doing, let's say in a year, like in the year. Like, how are the people doing in a year who had deep brain stimulation compared to the people who just had best medical therapy? Did we feel like, are we filling, you know, assisted living facilities with the DBS? What's she doing with those DBS cases? Interestingly enough, that study never got completed because the people with DBS were doing so much better that the people in the safety monitoring in the federal government, in the VA and the NIH, said it was unethical to take two people like this, there was no equipoise, and put those in the medical therapy with those conditions if they could get DBS. And that was published in the Journal of the American Medical Association, right? So it was in a medical journal in JAMA. You know, that was published in JAMA. I think Dr. Holloway was an author on that paper, and that's been cited thousands of times, that paper. People don't talk about it a lot, but in fact, if you have advanced PD and you're fluctuating, you have dyskinesias, you're taking a lot of medications, it's not as if you're not at risk for complications by not having surgery. You're a huge risk for all kinds of complications associated with falling, with behavioral things associated with the medication. So yes, unquestionably, surgery, if you look at it from a point of view, boy, you know, you could have a stroke. Yeah, it's very, but if you look at it actuarially, in terms of groups, like they did, there's no question that surgery is a much, much better option for that certain group of patients.
So who's on the patient's care team for this procedure? So of course we have a neurosurgeon. Does the patient interact with any of the tech med companies? Or is it all done within the patient's neurosurgery?
No, it's multidisciplinary in terms of the workup. Movement disorder neurologist is obviously involved, you know, because they follow and treat the patients and take care of the patients, and often have managed the patients and know the patients very well. The patients are seen by a cognitive neuropsychologist and have an evaluation first, because we know that Parkinson's is a brain disease, and their mood and their cognitive things associated with it, and we could talk about that afterwards. So we have cognitive neuropsychology involved. In terms of the surgery itself, you'll have neurophysiologists who are involved in micro-recordings and the setting of things. And then yes, industry plays a big role in this, because industry has developed technology. We've worked with industry over the years to develop technology, and they're involved in the maintenance and programming afterwards of these devices. So you've kind of illustrated a little bit about the typical progression for the disease and then what it looks like post-DBS, but talk to our listeners about how the progression of stiffness, tremor, abnormal walking related to Parkinson's changes after DBS. Yeah, so the point, we said what deep brain stimulation is supposed to do. It's supposed to help the motor symptoms of Parkinson's disease. It doesn't stop Parkinson's is a brain disease, right? This was not a cure for Parkinson's disease. It doesn't prevent the progression of Parkinson's disease. It will help the motor symptoms, and we've had people go 10, 15, 20 years out, but the disease progresses. Sometimes there's certain elements, motor symptoms of PD, which are not helped by medications. They often will not be helped by DBS as well. For instance, if you have terrible gait, if your balance is terrible, and even when you take the medication at the best of times, you never have good balance, it's unlikely deep brain stimulation is going to help you, like balance per se. And so those are the things. So we've helped the motor symptoms. The biggest challenge that I see as I move into the future and look at this, and I've following people for more than 20 years now, has been that the disease progresses. Right? Especially with respect to balance. We talked about balance, cognition, the non-motor issues of those. Those are like the huge challenges that we face in terms of treating this disease and finding ways that we can do that.
So for folks who are not experiencing motor symptoms on the onset, maybe more non-motor symptoms, cognitive decline, and then motor symptoms are introduced later in their progression, are they a candidate for the disease?
Yeah, so it depends. They may be. It depends what you're trying to accomplish. So in general, if someone is cognitively very impaired, this is usually tends to be in a much more senior population. We will treat, if someone has, let's say, is cognitively impaired but has a terrible tremor, which is impossible to control with medication, has a lot of cognitive issues but can't eat on their own because of their tremor. We'll treat someone like that because that actually, for the caretakers and people around them, really changes the level of care significantly. We've had some really have given people, and that's almost palliation in a sense, but we've really helped people for some years with that, and their caretakers and their families have been incredibly grateful from what we've accomplished. If you, however, have other symptoms that you have now but are also, let's say, very cognitively impaired, I think you should get away from doing things that are going to go directly on the brain. I think that's probably, you can make the cognition worse. Another thing I think that you need to be also really careful about is PD can also be associated with mood disorders, especially depression. And irrespective of your motor symptoms, sometimes you have to be careful if the mood disorder overshadows your entire PD, irrespective of what you are going to do for someone's motor symptoms, they will wind up seeing the cup half empty. And I saw that early in my career when we started doing this. We'd have patients who would come in who would, from a motor point of view, would just be spectacular compared to pre-op. They'd have no tremor, they'd be walking around, they'd be doing everything, and they would say to me, you know, Dr. Baltuch, I don't know why I had this procedure because I feel the same as I did before. I'm not happy. I'm not happy with this procedure. And I was wondering, and their whole families would go, well, what's going on? Like, why aren't you happy? Well, they were depressed. And it just took me a while to figure it out. And the treatment of mood disorder and depression is multifactorial. But it's and it's challenging. And often requires a psychiatrist who has real expertise in treating depression in people with neurodegenerative disease. Because the psychopharmacology of that treatment, and this is really outside of my scope of practice, but enough to know that the doses that you give for someone with just who has depression and doesn't have neurodegenerative disease, and the dose that you'll give to someone with depression who has PD is a whole different story. And that's an active treatment too. And we look at these as huge challenges in the future, things that we want to sort of get on top of, because we see people who are treated with motor symptoms who we treat, and we've done that well, and we continue to incrementally improve on that. But our next challenge is going to be, how can we stop the progression of Parkinson's disease? How can we stop this progression of cognition, progression of motor symptoms, progression of all these types of things? It's a huge challenge.
It is.
Yeah.
It is. With such an array of symptoms, and every patient seeing it and experiencing it so different, it is complicated as you analyze the myriad of symptoms that one person can have, and that's just one person, right? Well,
that gets me into, like, you know, what brought me to Columbia is, you know, I have been in this space for 30 years plus. You know, before I leave the party, so to speak, it would be great to throw a few more pebbles on that cairn and sort of make a little dent in these type of things. And I think that Columbia offers the potential to do that thing and it's a lead into talking about ultrasound.
Yeah, definitely. Thank you for making that segue. Our next set of questions will focus on focused ultrasound, which is a non-surgical procedure that was approved in 2016, as we noted, to treat essential tremors. So as we walk through that process, tell us what that procedure, focused ultrasound, is and what it entails.
So focused ultrasound is actually a few different things. And we'll start with what it's FDA approved for now and what it was developed for. And interestingly enough, it's the first indication is using sound waves and focusing sound waves and doing this in an ultrasound machine to make a small thermal lesion where you would have put the DBS normally, right? And making that thermal lesion and trying to do the same thing DBS does with the thermal lesion. This actually was pioneered in Virginia. It was pioneered in Charlottesville. You know where it really came out of, is where the Focused Ultrasound Foundation comes out of Virginia. Now thousands of people have had this. There's no incision. You just go into the machine. The sound waves get focused. You come out. It's a 1 to 2 hour procedure, and you go home the same day. It's primarily indicated now and approved, and insurance will pay for, is if you have tremor.
Okay.
So it's essentially used for tremor now. It was approved for essential tremor, which is different from PD. It's a different type of tremor, but it's also approved for Parkinson's tremor. Recently, we got approval for globus pallidus, to make lesions in the globus pallidus, so we can make lesions in the globus pallidus for other symptoms of Parkinson's disease, like the other motor symptoms of Parkinson's disease. But I don't think insurance is covering it yet. We're working on that. And there's some investigations now going on to use some different structures that haven't classically been used here in this country, but have been used in indicated in Switzerland. A target known as the pallidothalamic tract, which is under investigation now. We're doing a trial up in New York to see if we can mimic what we do with deep brain stimulation, making small lesions. The idea behind this is, again, no hardware in your body. A lot of people don't want incisions. A lot of people don't want burr holes drilled in that. And they're also, as our population becomes more senior, having deep brain stimulation requires being put under general anesthetic. When we put the wire and the pacemaker up, it's a longer procedure. We're seeing more and more patients who have increased medical morbidities, which increases their surgical risk. This is done without real anesthesia, so there's no anesthetic necessary, so you can do it that way. So you don't have any of the anesthesia risk, the hardware risks, etc. Focused ultrasound does have risk associated with, even though there's no incision, it doesn't mean there's no invasion. Like if you have radiation therapy, there's no incision, but radiation therapy can cause side effects. Similarly, when you're making a thermal lesion in the brain, it's not like you're just placing a wire in the brain. You're making a thermal lesion, so there's no eraser on the pencil. Once you go from, you make a test lesion to make sure first at a lower temperature to sort of see that you don't have untoward effects. But once you make your permanent lesion, you're done. Right. So there's no going back. You can't take it back.
Yeah, you can't pull the wire.
You can't pull the wire. You can't move it. So you can create permanent deficits, and you can make. The thing that people worry about the most is if the lesions classically are a little too big, you can have problems with walking afterwards, and you can make gait worse. You can have some numbness in the fingers. But all in all, it's been a great therapy as sort of an adjunct to have and everything's personalized. You know, as you look at it, focused ultrasound has really come along a long way. I personally don't think it competes with deep brain stimulation. That's controversial, depends on who you're talking to. I think there are two therapies that you look at, and you have to personalize it for for each type of person.
Sure.
Like outside, interestingly enough, so we look at essential tremor, which was the first big indication for focused ultrasound. We talked briefly about the DBS cases that we had done over time. The vast majority of those cases were actually done for people with Parkinson's disease. In spite of the fact, if you look, that there are 1.5 or 2 million people with PD in this country, there are 12 million people with essential tremor in this country, and like the meds are not really essential tremor meds. There's no real medication for essential tremor. The meds don't really work. Then why did we do so few DBS cases for essential tremor? It's because the population of people with essential tremor is very different from the population with PD, and they're very risk averse.
Yeah.
They didn't want deep brain stimulation, and we had a lot of people would come back to us who we had seen for years who said, no, don't want DBS. They come back and said, listen, I hear you have this new procedure now. I was reading about it, and can we get that now? Because I think I would like to have that. I didn't want the other thing, but I definitely want to have that. And that's the patients telling you that this is a kind of procedure that they want, that's attractive to them. And I think, again, it's important that we listen to our patients and hear what they are interested and they're wanted. So that's one type of thing with focused ultrasound, where you make thermal lesions. You can also use focused ultrasound to do something known as opening up the blood-brain barrier. This is really, really interesting because as we move to like this next stage where we would like to get biologicals into the brain, biologicals that would stop the Parkinsons from progressing, from moving forward. Neurosurgery has been very challenged as to how to get these biologicals. Like they go in, but they won't penetrate the blood-brain barrier. The blood-brain barrier is there for a reason, to keep bad things from going into our brain, but it'll also keep like things that we're trying to get into the brain. So we've tried with a variety of stereotactic techniques to sort of inject substances into the brain, and those procedures take a long time. We continue trying to do them. They haven't been super duper successful for us. We've done trials. Opening up the blood-brain barrier with focused ultrasound gives us potentially the opportunity to selectively find places and then just either with IV or intraarterial inject substances into those structures in the brain and not have to do injections anymore. So this could potentially be absolutely fabulous. They've done a few cases already in people in Canada successfully, and the hope is, you know, here in the United States that we're able to start doing this in the next few years, and this could be a way of looking at what, you know, this whole thing of restoration, of bringing biologicals in a brain in a way, in its delivery, you know, and this would be a way to deliver. Because that's really our next step that we want to do, and we're really fortunate at Columbia. So one of the engineers, Eliza Konafogu, who's also very involved with the Focused Ultrasound Foundation, is one of the pioneers of blood-brain barrier disruption using ultrasound. So if we could get a delivery, that would be just amazing. That would be, and we've done it in animals already. You know, it just, the leap to humans has got to happen next.
So talk to us about the candidacy for focused ultrasound. Is it the same for DBS, or is there different candidacy requirements? Talk to us about that.
Yeah, so for Parkinson's disease and people with fluctuations with Parkinson's disease, deep brain stimulation is still standard of care. I mean, the focused ultrasound stuff is still way on the investigational side in general, unless you have bad tremor, in which we can treat you. The motor symptoms, treating the motor symptoms, DBS, from a surgeon's point of view, is still your mainstay. I think you could get a pallidotomy with focused ultrasound. Now it's not yet covered. It may be for a select group of people. I still think DBS is going to be, for the next few years, the mainstay.
Okay.
Let's see what happens with the trials as they come along and we finish these trials like PTT over the next couple of years. The data from Switzerland looks really good. However, are we going to be able to replicate it with the trial in this country? Are we going to be able to replicate their data?
Right.
If we are able to replicate the Swiss data, we'll probably look at this differently. Then you'll be weighing both types of therapies, and we'll see that in the next couple of years.
Are you in a position to discuss how the things we talked about earlier, that or abnormal walking, tremor, or stiffness, is impacted post focused ultrasound procedure, or is it too early to talk about what it looks like?
Well, in terms, yeah, I mean, we know. At least for focused ultrasound pallidotomy, that it was FDA approved. So we know that the safety was pretty good, or the FDA would not have approved it.
Sure.
The data's not out in peer-reviewed literature. It's been submitted, and we're waiting to hear. So I don't want to talk about the data per se, but it's out there. I mean, but the FDA already looked at the data and signed off on it. If it hadn't been good, they wouldn't have signed off on it in its approved procedure. The question's going to be, are you going to get the efficacy, that you do with DBS?
Yeah.
DBS still has fabulous efficacy for people with Parkinson's disease.
I was going to ask, how fast post DBS does one see the benefits of the procedure?
I mean, I think that it depends on the person. For full benefit, I always tell people wait 6 months to see the full benefit of what this procedure can do, and let the programmers and your medication adjustment work with all those type of things. Some people see the benefits immediately. The next day the stimulator gets turned on and their tremors away and they're great. But I think for the most part, you should look at least 6 months and give it a chance, and with the medications, to see where you are with that.
Sure. Now, can you talk about focused ultrasound in terms of how fast one sees the procedure, or the benefits rather, after the procedure? Potentially, maybe it's just with essential tremor, but talk to us about the.
Yeah, with tremor, it's immediate, right? They come out. They come out. You could see it on the videos.
Yeah.
The tremor's gone immediately. It's right out. It's right away.
Yeah.
With respect to the motor symptoms, with the pallidotomy, they're seeing the stuff pretty quickly. Often it's the dyskinesias that you're treating on the other side.
Sure.
That's what we've treated a lot of, and it's pretty quick.
Okay.
But I don't think you're going to see. We know what the literature looks like for unilateral pallidotomy. It's not as robust as what you'll see with DBS. I mean, with deep brain stimulation, you're offering someone the potential of potentially reducing their medications considerably. A lot of people are just tired of taking that burden of medication.
Hearing the alarm, right?
Yeah, we don't want all the meds, and they can really reduce that. And as well, they're just so much more on time during the day. And then, yes, I'll have people say, okay, maybe my balance got a bit worse. Maybe my speech actually got a little bit worse for the DBS. And then the question you'll ask as well, if you had to do it again, would you get this procedure again? Pretty much everyone will say, absolutely. Yeah, absolutely. I mean, some of the worst things you could talk about hardware is when you have people who have hardware that gets infected and you have to remove it, and it's done so much, for their Parkinson's disease, and people say, please do not take this deep brain stimulator out. I don't want to live without this deep brain stimulator anymore. And then those are some of those challenging cases as to how you manage them in that way. But once people have this, for the most part, I mean, that's why we've done so many of them, was because this was a procedure that has worked so well. If you look in terms of the management of PD, I think Cinemet was an enormous breakthrough for Parkinson's medical therapy. I almost had an epiphany, I would say, the first time in the 90s when I saw Professor Benabid in Grenoble, who was the pioneer of this procedure, when I saw the first patient have DBS and change completely from bradykinesia and be able to get up and get around. Because prior to that, we had always thought of these disease states in terms of, you fill with meds, you're depleted, you fill, you give more now. Now what we did was we put wires in the brain, and we neuromodulated. We created neuromodulation. We changed circuitry in some way. And just by feeding electricity, you took someone who was sitting in a chair, stiff and frozen, and they got up and they were able to go around. That was, I think, you don't have a lot of epiphanies like that in medicine. That was, I think, my first. And my second was seeing someone in an ultrasound machine go in for 2 hours with no incision, come out and not have any tremor anymore, and just go get up and walk out the same day was, the second one. I just really, I feel so incredibly grateful to have been able to experience this. And the next thing we're trying is to do something where we can try to prevent, progression of PD. I mean, people talk about cure all the time in Parkinson's disease. One of the things is once you get diagnosed, right, you've already lost, what, 80% of your cells, or I don't know what the exact number is, but so now, okay, you got 20% less, so we can't give you back necessarily what you had, but let's prevent and keep where you are so you don't move forward anymore. I think the toughest thing that I've seen in my career is people progress in their PD, over time. Even though we control motor symptoms, they've progressed. They became cognitively impaired. A lot of my patients passed from complications of PD, although they had great quality of life from the DBS, which really improved their quality of life over years. If we could prevent that progression, I think that is the next huge step, especially the cognition. The cognition and the gait are the two things that I think in my mind, because I think falling is what injures people, and that is really terrible, and cognition is what really devastates people and the people around them. And so I think those are like sort of the two big challenges, as we say, that we work on doing. And then within, as you say, within DBS, trying to get the stuff a little more fancy and sophisticated, so it becomes a little easier, a little more efficient, a little more user friendly, and just a little bit better. I think those are the incremental things we'd like to do. The big picture, big vision is prevent progression of disease.
That's a lofty goal. it's an important
It's a goal, but it ties into other things too. It ties into a bigger picture. It ties into Alzheimer's disease. It ties into depression. It ties into a lot of different constellations.
Well, you're doing these procedures, but then you still have the progression ultimately on the non-motor side. So
correct.
Well, tell us, is the intervention for both of these procedures done at the same time in the Parkinson's continuum, if you will, or does one become an option prior to the other? Are they both at this point, okay, you're eligible for either the DBS or Focused Ultrasound? Talk to us about when someone can consider one of these procedures.
Well, I still think that DBS is more standard of care. It's tried, it's true. They've done, 250,000 procedures. It's been around. It's been around 30 years now. Deep Brain Stimulation. So I think that is sort of your standard. A lot is known about it. There's huge literature. Focused Ultrasound is very new. It's on the horizon, so to speak. It's available if you have bad PD tremor and you want to try it. Once you have DBS, you can't get Focused Ultrasound yet because the waves bounce off the wires, so you're not a candidate for it. But it's something that you could think about if you had tremor and you weren't interested in having, let's say, wires or neurosurgery. And the other motor symptoms, it's still like not being, Medicare approved. So I think wait and see. Wait a couple of years and see what happens. But I think it's an evolving process. So you may want to then wait if you're not ready to have like a major neurosurgical procedure, and see what happens with ultrasound over the next couple of years.
Talking about just deep brain stimulation, what impact or what relationship does it have on the standard dopamine enhancing medications? Are most folks able to maybe not eliminate it, but significantly decrease? Talk to us about kind of generalities in terms of what you're seeing regarding that relationship.
Yeah, I think for the most part, I tell people 50 to 70% reduction in medication dose with deep brain stimulation. I'm not a movement disorder neurologist, but I tell some people like eliminate their medications completely. I think PD is still a brain disease, so you should take a little bit of medication, just a bit. I worry about the people who get their DBS and then, you know, they throw all their meds in the river the next day, and then they wonder why they, you know, sort of bottom out afterwards. But I would say 50 to 70% reduction in medications is a goal, and I think we work, and this is a surgeon speaking, I like to get the meds down. You know what I mean? I'm not a huge proponent of a lot of medication. I like a little bit of medication. I think a little medication is good. A ton of medication is not good.
Well, I mean, there's so many side effects, and then you're strapped to your phone with the reminders to take your medication, and that impacts your quality of life over time, of course.
What we get in the office are people tell us we don't want to take all these pills.
Well, talk to me about what a patient should do if they're interested in learning more about these two procedures, particularly if they're discerning, they're just starting to learn about focused ultrasound, they're discerning which one's right for them. Where should they go? What do you recommend them do to seek additional information?
Well, I think the first thing to do is to speak to your neurologist who's treating you for your Parkinson's disease. And if they haven't brought up any of these therapies with you, take the initiative and bring it up yourself and see what their response is. If they say to you, I think you're doing fine with the pills, then be willing to counter and say, no, I don't think I'm doing fine with these pills. If they want to give you more pills, tell them I don't want to take more pills. You know, I've taken enough pills. Look how many pills I have in this pill box. I'm tired of taking pills. And then see what they are willing to say, you know, versus these therapies. And talk to them about, you know, am I a candidate for these procedures? And have that discussion with your neurologist, serious discussion with your neurologist. And then if they're amenable, see if they will give you a referral to see a neurosurgeon, right, who deals in the surgical treatment of movement disorders and has experience in treating people with deep brain stimulation in a center that does this relatively frequently, you know what I mean? And then also see if you can get to talk to people if you're interested in focused ultrasound, where focused ultrasound is being done and who does it and why. And then go get yourself a few opinions about this and inform yourself. You know, and then really go inform yourself about these type of things.
What would you say to the patient who's a little apprehensive if they are in a standard practice, maybe not at a research institution or medical facility that has a neurosurgeon? What advice would you give to a patient who may need to kind of look outside their current practice? And is there connectivity between your general neurologist and some of these centers?
There should be. There should be. And I think that the place to start with is to ask your general neurologist to say, listen, I think I would like to be seen in a bigger center. You know, I don't think you have to be shy about asking about this. You know what I mean? I think I'd like to be feeling better. I've been reading about this. You can actually come and show them some of the literature. You know, and I think most neurologists are just so busy these days that they're more than happy to refer you in to a specialized center that sees people like this all the time.
I agree. Well, Dr. Baltuch, as we summarize, where can our listeners go to find more about you and Columbia Medical Center and all the research that you're doing?
Well, I mean, the internet is a fabulous place. You know what I mean? There's all this information on the internet that you can get, the good information, the bad information, and go read that. You know, if you want to read about like these studies, go to Google Scholar. You know, put my name in. Put Dr. Holloway's name in and see what Google Scholar comes in. You can read these articles themselves, you know what I mean? They're not that incredibly difficult to read. You know, read the trials and what they showed. Look at the data, you know, re ipso locator, the data speaks for itself, you know what I mean? That's why they're in those big peer-reviewed journals, you know what I mean? Because those are the data. And people like to look at those data and then go and look at the testimonials, the good ones and the bad ones, and then make your own opinion, looking at all those things, and then look at the trials that are being done, and look at what's being done at Columbia, look what's being done at MCV, look what's being done at all these places. If you have the time, you go on the internet, you can get so much information.
Yeah, well, I know this was extremely helpful for our community, so I can't thank you enough for being part of the series and providing not only information, but ways to advocate for yourself as a patient. So thank you so much, Dr. Baltuch.
Thank you, and thank you for having me.
Yeah.
That's just great.
This was great. So as always, we'll have information about Dr. Baltuch, where to find him, where to find some of these research avenues so you can kind of take your diagnosis and next steps by the reins and advocate for yourself. So again, thank you so much, and we'll see you soon.
Thank you.